is recorded? I hope you don't
Uh,
mind. Should have
No,
asked.
not at all. Not
And
at
I will
all.
post it with your permission on my YouTube channel and on my website, my landing page for Carepatrol.
Right. Okay.
All right, and now I'm going to admit everyone. Welcome, welcome, welcome in, y'all. Welcome to Care Concierge with Carepatrol, where education is the heart of everything that we do. We appreciate you joining us. We've had a little layoff from our last CEU class. So today, Monday, November 7th, we're rejoining you. And our theme for November will be just as it was in October, which is either clinical or professional topics delivered by clinicians and or professionals. And any of you who work in the long-term care field should pay attention to our calendar, as we have a Hodgkin's disease, Huntington's disease presentation by Dr. Dees, a neurologist from Mobile, at the end of the month, which is, I'm sure, to be very helpful for anyone caring with that patient population. We appreciate y'all being here today for today's topic with Care Concierge, with Carepatrol, which is EMS, the mess. And we had quite a number of folks register for this course and are certainly now attending. And we appreciate you. And I know it's for two reasons. One, the title is grabby. It gets you. EMS, the mess. But two, I expect that a lot of you have had the pleasure of interacting with our speaker today, who is Captain Rusty Lowe, retired, who in his 36-year career spent 30 with the city of Hoover in their EMS department, retired as captain there, serving in that position for 10 years. And I'll tell you a couple of stories about Rusty. I've had the pleasure of knowing he and his wife for a number of years. And in fact, many years ago, he doesn't know this, but many years ago, he and his wife would go to dinner at a restaurant where I worked. And I had this impression of Rusty as the fireman to the stars, sort of. She was a glamorous woman and good friend. And I saw them eating where I was serving, and I thought, they're just a power couple. And so I was glad to note that as we grew older, we had children the same age, and it's more than once, many times. I've seen Rusty on the court or on the field or on the diamond with a child who twisted an ankle or hurt a knee or did something else. So he's a person who not only works and has worked as a paramedic for his entire career, but he's someone that lives what he says. He lives what he preaches. He is who he says he is. And this is one of the reasons I'm so humbled and grateful to Rusty for speaking with us today. And I know that you all are happy to hear his topic. I'll tell you just a little housekeeping before we get started. If you're new to Carepatrol and Care Concierge, our educational series, we do an evaluation process that's online through SurveyMonkey, and we use a password protection system on that evaluation so that you must listen to the entire presentation live in order to receive the certificate, which is a live credit or a face-to-face credit. So you must do the evaluation to get the certificate. If you're a nurse, we'll post your hours on the ABN website. If you're a social worker, you'll have our certificate and email verifying that this was a live CEU for you today. The address, I know oftentimes we have folks, and I'm just letting one in, folks who are by phone, who cannot see a screen, who need to know the evaluation link. And so I will say it now for those of you who need to make note. If you can't see a screen, take note on paper in your phone. However, you do so. Our evaluation link today is a Survey Monkey link, and it is https://www.surveymonkey.com/r/ all uppercase letters 7YJ9SWF. And I'll read that one more time for those of you who need to make note. If you've just joined, we have an evaluation, a process by which you get awarded your certificate. You must complete the evaluation for us to award the certificate. It is password protected. We give the password out probably around 12:50 or at the end of the presentation today. And the link that you'll want to use is https://www.surveymonkey.com/r/ all uppercase letters 7YJ9S as in Sam, WF as in Frank. And Ms. Witherspoon, per the upcoming CEU schedule, there's 2 CEU scheduled on 11/21. That's not correct. They pointed that out to me. So anyone looking at our calendar, you know, I am someone who's prone to user error, and I made the incorrect posting. So it is not the 21st. It is today. I'll get y'all a calendar out in our email when you do the evaluation for the correct date. And thank you for pointing that out. Thank you, Ashley, for posting the link for us. And I want to remind all of you that we encourage discussion. We hope this feels like a safe place where you can share your experience and wisdom with us all. And so you have the ability, each of you, in addition to being able to use the chat room, you all have the ability to use the mic so that you can unmute. So it feels like that many of us are now here. Thank you all for joining us. Again, I'm going to thank and introduce Rusty Lowe, retired captain from Hoover EMS Services. He's going to share with us, and I'm very much looking forward to it, share with us today, EMS the mess. So thank you, Rusty, and please begin.
Thank you, Sean, and I'll pay you for that introduction. I think my mother's the only one that can talk more nicely about it. Thank you very much, and hello, everybody. I appreciate you being here today. As time has gone on, you know, things have changed in everybody's profession, and it's definitely changed in healthcare, and then all our different jobs and what we do in healthcare. So I kind of wanted to focus today on EMS, and I call it a mess because it is somewhat of a mess right now. Any of you that have dealt with an EMS provider lately in your own environment, whether it's clinical or social, you know, it may have presented a difficulty, and I'll talk about some of those difficulties. One of the reasons why I feel a little more versed in this category now is my mother's 91 years old, and she is a resident at Greenbrier, and we've had interactions with ambulance transports and EMS lately, whether it was an emergent trip to the emergency room or if it's been a trip back to the facility. And what I wanted to do is just kind of go through the EMS provider's side of the story and kind of let everybody know what's going on in EMS right now, and or what's not going on that should be, and hopefully give you a better view of what's going on in that paramedic or EMT's mind when he comes walking in your facility and looks like he's been hit by a train, and looks like he's been working for 2 days straight without any sleep, because there's a good chance he may not have. So go back through a little history, tell you a little bit about EMS, and then we'll talk about some of the current problems and kind of bring us to the conclusion and some discussion at the end. Please feel free to stop me, ask any questions, and I hope that I can enlighten you just a little bit. So I want to talk a little bit about the past, present, and the future. What may go on. We just predict what may happen in the future, but I also want to offer a few suggestions. I still keep in contact with people in the EMS world. My present job now is sales for Go Rescue brands. We sell AEDs and cardiac monitors and such life-saving equipment. So I'm around my people all the time, and so I hear what they're going through, and now I'm going through it myself with my mother. So let's just get on into what we're going to talk about. As far as the state of Alabama and around the country in the early 70s, there were just a lot of traffic accidents happening. A lot of people were getting hurt on the highways and getting killed, and there was no real care for them. The ambulance services were there. Most of them were owned by the funeral home, and the funeral home, it was a win-win situation for them. If they picked up the patient and they made it, they got them to the hospital. If the patient didn't make it, they took them on to the funeral home. So say that a little jokingly, but that's the way it operated. So in the early 70s, maybe the late 60s, a lot of doctors got together, not just in Alabama, but around the country, and came up with the first EMT course. Now, that wasn't a paramedic course yet. It was just strictly EMT, kind of advanced first aid, a little bit of step above what Red Cross was teaching. There was a white paper done by the Department of Transportation throughout the country, and a lot of funds were put into this initial wave of training. Private ambulance services, if they didn't work for the funeral home, were under-equipped. The personnel was poorly trained. And basically they would get to the scene, throw the person in the back of the truck, and they would fly to the hospital as quickly as they can and turn them over. Now, some of those protocols are in place now for trauma victims. And so it's almost like we've become full circle sometimes, but for the most part, an ambulance or EMS unit should be able to provide some treatment on the scene to stabilize the patient before they get them to the ER. That's separate from a transfer from a facility to facility. The paramedic program started around 1973 in Jefferson County after the TV show Emergency came on. And Emergency was a show about the LA County Fire Department, and there were two paramedics, Johnny and Roy. And people of my generation that got into fire and EMS attribute it to that television show. And also the modern day EMS system was given a really big boost. In 1973, UAB graduated the first set of paramedics from Birmingham, Homewood, and then Vestavia Hoover had a unit. So there were 3 paramedic units in the county then. They were fairly busy, although it took a while for them to be recognized as far as what they could do for the patient in the field. Back then, the highest acuity patients went to the closest hospitals, not specialty centers, or there were no freestanding emergency rooms back then. It was a tiered system where the fire department rescue got there. They treated and stabilized the patient. The private ambulance service transported the patient to the hospital with one of those paramedics in the back, assisting and continuing care. Then Jefferson County put units in Center Point, Bluff Park, and Concord. And throughout that time, several firefighters and others went through the paramedic course, and it really got a big boost. UAB kind of took the lead then and helped share the love and get the training out there. And the fire department, the fire service got into the paramedic service in the beginning because the strategic location of the fire stations could put a paramedic unit close to you. In the early 80s, everybody wanted to be a paramedic. When I went to paramedic school, there were probably 30 or 40 people in our class. It was like, well, this is a noble job. It's a good job. Let's do it. Private ambulance services started hiring paramedics and had actual paramedic equipment on the ambulance. So that's just increasing the capabilities throughout the county. You had Hanks ambulance, you had A&A ambulance, suburban ambulance. All those services really started increasing care and just put more paramedics on the road. The training was increased. I know when I when I went through paramedic school, it was 3 semesters long, and we were out. And then as time went on, the training's increased, and now to become a full-blown paramedic, it takes almost 2 years. The ACLS guidelines were improved, and survival rates from cardiac arrest were starting to improve. And then the trauma and specialty centers were developed, and so we weren't necessarily taking patients to the closest hospital. We were going to Caraway or University or one of those trauma centers that was specified as a trauma center and had 24/7 coverage that could handle some of our worst patients. Several of the other hospitals became stroke centers, and that's kind of been revamped here in the recent past. And so during the 80s, things were really happening and going on, and everybody that was my age or younger or even older, some people decided they wanted a new career in EMS, and everybody was excited when there was a firefighter test given for the fire departments. There were hundreds of people that were taking the test and wanting these jobs. And at the time, it paid fairly well.
Let me stop you. There's a few things that you said. That is it ALCS guidelines. What does that stand for?
Yeah. Okay. That's ACLS is the Advanced Cardiac Life Support from the American Heart Association.
Okay.
And it's a set of guidelines for treating cardiac arrest and heart attack patients and any cardiac issues. And when those the research started showing that different therapies, including defibrillation and some medications that are given, were appropriate for cardiac arrest patients. And as those guidelines changed and were improved, we saw a little bit of a rise in the resuscitation rate in the area, even though it continues to be usually less than 10%. We were still seeing a little bit of a rise in the survivability of our patients.
So wait a minute, 10% is the survival?
Out of hospital cardiac arrest throughout the United States is less than 10% usually. Now, there are some cities that have improved their care system and have trained a lot of people in CPR and have a lot of AEDs out there, and their resuscitation rates are higher. But typically, and it's still that way, even though we've improved our treatment, that the survival rate from cardiac arrest that occurs outside of the hospital is less than 10%. And that's why we continue to preach CPR training, AED placement, and cardiac care centers in rural areas. The perfect scenario is if someone has a cardiac arrest, that someone starts CPR immediately, calls 911, that there's an AED close by that can be used, and that EMS has a good response time within 10 minutes to arrive at that patient's side. If any of this is interrupted or the time is greater than 10 minutes before any treatment is initiated, the rate of survival for the cardiac arrest victim slowly but surely decreases by 10% every minute. So time is definitely of the essence.
That's amazing. And I'm just thinking, I mean, if 90% of the people that you attend don't make it, I mean, that's a fairly trauma-ridden job.
It can be. And luckily, there's support for that. And that as time goes on, those numbers are slowly but surely increasing. So, that's always a tough topic, whether the patient's 90 or whether they're 9. Cardiac arrest is the most serious issue we treat. And we understand that sometimes that the patient wasn't meant to be resuscitated. But we also know that if the proper things are done within the proper amount of time, that the survival rate is greater. And so that's something that we really are working on, and that hopefully we'll see better resuscitation rates in the future.
Yes.
All right. So in the 90s, we continued to improve the EMS system. We had more training and increased capabilities. We were able to carry more specialized equipment, different medications. As time went on, our protocols were evidence-based. Initially, when we started EMS, it was thought of, well, if it works in the hospital, we can put it on a truck and it'll work in the field. And that's not necessarily the case with certain equipment and certain medications. So slowly but surely, as we participated in field studies and became more alert to our patient outcomes and had better follow-up through the hospitals, we were able to increase our capabilities, and training was funded, and the continuing education was the biggest part that was lacking in the past. And in the 90s, it really picked up. We still had an increasing number of students in the EMT programs, even though they were getting just a little bit longer. It took longer to do it. And the trauma and the specialty centers really flourished. They were increasing capabilities of the hospitals. The trauma centers were working very closely with EMS in the field to develop protocols to be able to treat the patients and get them into the hospital in a hurry, using the golden hour, the amount of time after the person has sustained a traumatic injury and they're in shock. The golden hour is very important to get them to the trauma center where they could have surgical intervention as soon as possible to help correct their trauma and reverse the shock. And this really flourished. And especially in the Birmingham area, we had 2 level 1 trauma centers, being Caraway and UAB. And we really saw the improvement in trauma and burn care. And that's when people from all over the Southeast started coming to the Birmingham area. And we were able to really flood that system with several patients, sometimes whether it's a mass casualty incident, whether it would be just several patients from all over the county and all over the state at the same time. They were really able to handle these patients, and it was very easy to get our patients to the hospital and get them treated quickly. And like I said, the evidence-based protocols were really coming to light, and we were really learning a lot of stuff about what we were doing, what was right and what was wrong, and we were able to make corrections.
Let me stop you again. I'm sorry to interrupt you so
All right.
much, but you said
That's
something that interested me, the golden hour, and I wanted to hear a little more about what that refers to.
Yes, back in the, I guess it was back in the 80s, we'll say, Dr. Cowley in Maryland and some other trauma surgeons throughout the United States started looking at the outcomes of trauma patients. Paramedics would go to the scene, would attempt to stabilize a patient with IVs and other treatment, and then transport the patient to the hospital. Maybe an average 15 to 30 minute scene time. Well, they started looking at these patients and determined that the quicker that the patient could be transported to the hospital with less time on the scene, the survival rates were improving. So they started calling that the golden hour. And so with the trauma patient, from the time of the injury, the greatest chance of survival for that patient was to get that patient to a hospital that was a trauma center that could surgically intervene in their traumatic injury within an hour of the time of the injury, not the time the EMS arrived, from the time of the trauma. So if you had someone hit by a car and it took EMS 5 to 10 minutes to get there, you've already lost 10 minutes there and you've got 50. The 60 minutes wasn't absolute, and but as close as you could get to that 60 minutes that we call the golden hour, the greater the chances of that patient's survival are. In and around the Birmingham area, we still have UAB, and as the trauma center, talk a little bit more about that in just a minute as far as patient load in all our hospitals. But these patients, if we could hurry up and stick them in the back of the ambulance and do treatment on the way to the hospital instead of on the scene, the greater their chances of survival were.
It's fascinating. Thank you so much for educating.
Well, yeah, you're welcome. Well, glad to do it. So we were kind of in the heyday in the 90s here, especially in our area. We had a lot of ambulances on the road. We had a lot of rescue units on the road. We had helicopters in the air. And patients in and around the Birmingham area and throughout the state were actually receiving pretty good care, even in the rural areas. So time rocked on through the 90s and into the 2000s, and here we are in 2022. And what we've seen over the last several years in EMS is things are starting to decline. You know, it's almost like you know, we plateaued in the 90s, and we're starting to kind of taper off. We've got declining number of applicants at the EMS agencies. COVID just had a heck of an impact on EMS and the whole healthcare system and everything. I mean, everything in the United States. I don't care what you did and what you still do. COVID had a tremendous impact, and I'm preaching to the choir here. But it really has taken its toll on EMS workers, and people have left the profession to do something totally different. They're going to work at the Amazon warehouse. They're going to work in the hotel industry. They are just getting out of it altogether. PTSD has been a big problem. We recognize that with the military and with police officers and with EMS and firefighters. We've seen increasing numbers of suicides and attempted suicides within the profession. Some people locally that I knew that I never would have believed would do anything like that have done it. And it really can have an impact. And in the past, if you were in our business, and pretty much everybody in the healthcare business, if you saw something bad and you showed emotion, you were told to shut up, suck it up, and keep working. Now we recognize that obviously was the wrong way to do it. Those of us that are like me and like some of y'all that have been doing it for a long time, you know, we have that, you know, we're crusty, we're tough, and we have that personality that back then is how we had to deal with it, as to where now there are systems in place for pre-hospital care providers, for EMS professionals to get assistance with PTSD and to monitor it throughout their career. But some people call it burnout, some people call it whatever. But, you know, I recognized at a certain point in my career, luckily I was able to retire, that I won't necessarily call it PTSD, but I saw an opportunity to retire, and it was just time. I knew it. I feel like if I'd gone on any longer, I might become a little hardened to things, and you know, might experience some. So, you know, I was lucky to recognize that it was time to retire and move on. I'm still involved, but not to the level that I was before. Other people have continued to work with assistants, and I hear from some of them from time to time, and sometimes you can only see so much where you have to move on. So it's real and it's out there. PTSD is some people used to call it imaginary, but I beg to differ. Violence against EMS personnel. Used to, if we showed up to the scene of a call, no matter what type of incident it was, whether it was a violent incident, whether it was a medical incident, whether it was just a routine call, you know, no problem. We were the good guys and gals. We were there to help. We provided aid and never worried about getting hurt. Rarely did an EMS provider get hit over the head, get shot, get stabbed. Very rare. Throughout the country, that has increased, and that attributes to some people leaving the field. Some EMS agencies wear bulletproof vests. Some EMS personnel throughout the country are now armed, and so the uniform sometimes is under attack, whether it's police, fire, sheriff, ambulance, EMS, whomever. If you're wearing a uniform, you have to really guard yourself closely, and it doesn't matter what demographic you're in. It can happen in the richest communities and in the poorest communities. It's happening all across the board to EMS personnel throughout the country. Pay or lack thereof. I got ahead of myself. All right, pay or lack thereof. A lot of these agencies are paying very low on the scale, and benefits are not what they used to be. So we're losing people. All of these things that I've just talked about are causing us to lose people. And when there was a job that was advertised before, when maybe 5 or 10 people per position wanted to apply for the position, we're really having trouble finding people. Another thing you'll see is sometimes the agencies are begging for people to work, and the EMS providers, firefighters, police officers are working second and third jobs to make ends meet with the salary. And a lot of people out there are struggling. There's you can go many places and make more than the average EMS worker in the United States, and you've got a highly trained individual that, due to paid benefits, the threat of violence and all that, they're going into other fields. Now, luckily, some of them are going into nursing, PAs, physicians. Some of them are going ahead and moving on into the healthcare system, but that has its stresses as well. So it's really a tough time to.
Rusty,
yes.
how is EMS funded? I guess in Hoover's case, it's through the city.
Right. If it's a city, it's funded through taxes through the city. If it is a county agency, which there's talk of that in Jefferson County now because there's an ambulance shortage in certain areas of the county. A lot of services are private. Those of you that are in the area, that would be like RPS, Careline, Care Ambulance, Haynes Ambulance in Montgomery. It's totally private, and their success depends on their collection of fees after they make the call. Now, the cities in the Birmingham area have gone into the transport business, where they used to be just in the first response business, and the cities are now running ambulance services within the cities. And when they charge for that ambulance ride to the hospital, that goes back into the general fund of most cities, but it's earmarked where some of that money that's coming back in can help pay for equipment and manpower and others. But once it gets back into that budget of the city, it's up to the fire chief to convince the city councils, county commissions, and all that to put some of that money back into the departments. So the private ambulance services, on the other hand, they're hoping that Medicare helps pay for the trip for the patient. They're hoping private insurance pays for it, and then if it's a situation where there's a balance, that the insurance company or Medicare will let the patient pay the balance of that, they're hoping they can collect that money. And as the economy gets worse, it's harder for them to collect, and especially with the high rate of unemployment. So it can be difficult. And the state throws in some funding sometimes, the county throws in some funding sometimes, but that's not on a regular basis. And it's up to the managers and chiefs and owners and CEOs of these companies to rely on their politicians for some assistance. Now, the CARES money during COVID and some of the other money that's out there during COVID has helped, but that, that's a one-shot deal. So a lot of the services were really trying to figure out what equipment they needed and what type of vehicles they needed where they could get some assistance, because during COVID, they were stressed to the max and a lot of equipment was used more than it should have been. And some of the trucks were run ragged and need to be replaced. And so there's no regular golden egg like they were given during the heyday of COVID. So it can be real lean sometimes, and especially in rural counties like Greene County, Alabama, that EMS service struggles to stay afloat every day. And about 6 months ago, they were within a day of closing down, and the state came in and some of the local municipalities were able to kick in some money to keep them going, where they would have an ambulance service in their county. They were real close to not having one. So you see the danger and you see the picture I'm painting here, and hence the title, EMS the Mess. it's really tough to keep that going and to provide the service that everyone's been used to in the past. Services are doing more with less, and I would venture to say that everyone on this phone call in some way, form, or fashion in your profession now, you're being forced to do more with less, whether it's not filling positions or whether it's eliminating positions, or if a patient load has been increased and the patient to provider ratio is larger than it used to be. But it's happening in the back of an ambulance, it's happening in the hospital, it's happening everywhere. So when you see that guy come in and you're transferring a patient out or receiving a patient back to your facility, these guys have really gone through a lot. And I'm not taking that away from any other sector of the healthcare community right now. Everybody's had it tough. And, sometimes people are fairly raw, and it can be really difficult. As far as transport times, transferring patients, I understand sometimes in the Birmingham area, patients have waited 2 to 3 days to be discharged home from the hospital because an ambulance can't get them. When you're looking for a patient to be routinely transported to a hospital when it's not an emergency, not a 911 situation, but the patient needs to go to the hospital, the response times, I understand, are just phenomenal and through the roof. I've seen that firsthand myself, and I know the people in the system. And they say, "Hey, Rusty, I know it's your mom, but we don't have anybody available. We'll get there when we can." And if y'all see my screen, that's my mom calling right now, but I'll call her back shortly. All right, have I lost the shared screen?
Somehow the share went away. Now it says you're sharing.
It says I'm sharing. Let me see.
Share device. You turned it off. That didn't make. Oh, there it goes.
All right.
I feel like we're close.
We had it earlier. My apologies, y'all.
There's the blind leading the blind, I'm afraid. Well, the rest of you can see better than I can.
I'll tell you what I can do here.
Let me ask you a question while you're looking.
Okay.
A couple of things that occurred to me, but in healthcare generally, you talk about the patient's right to choice. Is there such a right when it comes to which EMS service comes? For example, a private company versus a city-owned?
You can make a request, but typically the system is where if you're calling 911, and you're in the city limits, the city responds, and sometimes there are protocols where they'll initially start to treat the patient, and then will hand the patient off to the private ambulance. In certain areas, you may only have one provider. So typically, there's not a whole lot of choice out there for your provider. If it's a non-emergent situation, of course, you have a choice. You can call the private service, but the private service may not have anybody available and may not be able to respond and get on the scene to where they need to be. So it becomes a little tough.
I can see on the half of the screen the slide. We could even work from that way, maybe.
Okay, let's do that. I don't know how to get it. I don't know how to get it going.
I was going to tell you before I forget, Rusty, and for the folks that do what you do, we have later this month, I think it's on the 21st or 24th, a psychologist who's going to talk about vicarious and secondary trauma, which is something. There it is, perfect. Which is something that your position, the EMS position, would be, very, succumb to.
Sure, that's interesting. Thank you for doing that. All right, so back where I was on the present, we were just talking about the problems that exist within the system as far as being able to get an ambulance to the scene and get that patient to the hospital. And then when it comes to long-term care, the ability for that patient to be transferred from one facility or another, or just be transported for a doctor's appointment or evaluation or something like that. That is really, really burdening the existing system out there. And a lot of services aren't able to run as many trucks because they don't have the personnel. They'd love to hire them, but they just don't have the personnel. So it presents a problem. And I know people on this call have probably experienced that before. And when we get into our discussion, I'm sure I'll hear some situations. So in the future, you know, this is a little bit my opinion, but I think there's some things that maybe we can do in the future. And, you know, I didn't put it on here because it's the elephant in the room, is more pay and better benefits. People in all professions are struggling with that right now. I don't know the answer, but that would definitely increase service if you're able to pay these people what they're worth. All healthcare professions. I don't mean to be just singling us out and being stingy. Better pay and benefits retains more people and gains more people. One thing some people may not know, if you do work in different states, that EMS in every state and sometimes in counties in certain states operates under different protocols. There's not one standard protocol throughout the United States. So that has presented some problem with federal funding, where people are trying to get federal funding for EMS. It just can't be a blanket deal. And there's been some work to streamline the training throughout the United States, but it hadn't really gained a whole lot of traction. Luckily, in the state of Alabama, we're regulated by the State Board of Health and are able to keep our protocols streamlined in the state. If I'm a paramedic in Jefferson County and you're a paramedic in Mobile County, you're licensed to do the same thing. I did put it on here, and the pay and the benefits need resuscitating in all healthcare. We could beat that to death all day. New technology. There's a lot of new technology out there that is helping. Whether it's patient monitors that transmit data in real time, whether it's smaller and easier to use equipment. There's new stretchers out there that are back savers for people that are lifting people on stretchers every day. There's technology out there that can actually, based on past history, look at where the calls have been and where they're going to be to, and kind of shift the system status, shift units around to be kind of in the right place at the right time. Monday through Friday, you know, I see the ambulances posted down near St. Vincent's, down near UAB. They know there are going to be so many discharges, and they're doing everything they can to try and to regulate that and streamline it as to where there's a little more order to it. Retainment of personnel, can't say enough about that. You got to keep your people, and you got to figure out some way to keep them and take good care of them. Combining resources, that's always been a little bit of you know, my truck's bigger than your truck. We have 5 trucks, you only have 3. Slowly but surely, some of those walls and those borders have been coming down over the past few years, as to where the private service is helping the other private service. The public services are working with the private services, and where we're not duplicating equipment, where we're not duplicating coverage, and where we can share the expense with other cities, with other facilities, as to where the equipment and manpower that's out there that's needed is not saturated in one particular area. I've happened to work for one of those cities that we had all the new trucks, we had all the new bells and whistles, and we did our best when we could to assist other agencies. But you know, you're primarily responsible for your own jurisdiction, so you have to make sure that's covered before you can assist somebody else. However, there are a lot of operating procedures in place now where cities are helping other cities. And I know right now Jefferson County is working on a deal to get the west end of the county covered by existing resources and by new resources being brought in, because it was definitely determined that the west side of the county had very poor, if any, EMS coverage at certain times of the day, even to the point of 911 operators telling people to load their loved one in a car and get them to a hospital as quickly as they can. They had no ambulances to send. That happens more than we want to admit. So a lot of problems, but there's a lot of solutions out there. There's a lot of people that are working really hard, not just here, but throughout the nation. I travel a fair amount, and when I'm in these other cities, other states, the problems are the same. They don't have enough people, they're not getting paid enough money, and the system's overwhelmed. So, you know, the EMS system is a mess right now. I don't really say that to scare people. I want to say that for people to take note. And when you're utilizing EMS in your facility, in your job, in your home, you know, are we using the system appropriately? The last little bit I'll talk about before we get into the discussion is community paramedicine. It's been identified over the past few years that in certain cities, Birmingham's done a little bit of it, Tuscaloosa's been doing a little bit of it, and they've identified what we call as the frequent flyers. And why are these people calling 911 every other day, once a week? Why are they going to the ER and being sent back home? And what the community paramedicine program does, it reaches out to these individuals and goes to talk to them in their home. And these firefighter paramedics say, you know, hey, you know, we're not criticizing you for calling 911, but what is the reason you have to keep calling us for help? Is there anything we can do? A lot of times it was the patient was discharged home with their medicine, said, take this medicine 3 times a day. They were taking it 3 times, just taking 3 pills in the morning, or either they weren't taking the medicine, they never got their prescriptions filled, or is it a family neglect issue where DHR needs to be brought in? And they have actually, in the communities that are really doing full-blown community paramedicine, some of them are sending a nurse practitioner and a paramedic out to the patient, and the nurse practitioner is actually able to write a prescription or give a certain amount of treatment that a paramedic can't do, and the patient's able to stay at home or either get their initial treatment and then be taken to the doctor's office where the 911 system isn't overwhelmed. This has been well received in some communities. Birmingham is doing it, Tuscaloosa, and the cities with a large volume, it's typically in the elderly population, but sometimes it's a young person that's on dialysis. Sometimes it's another patient. But it's not weeding out patients. It's just routing patients to a secondary location where they don't get into the ER, you know, 2 or 3 times, and the ER really can't do anything for them, but send them home. And the community paramedicine, I think you'll see grow in our field in the next few years. And I think it'll be really effective, especially to the patients that do not need to go to the ER, because the way it is now legally, when a paramedic or EMT in the state of Alabama arrives on the scene of a call, and the patient is treated, we're always going to recommend that they go to the hospital. We can only do so much. And sometimes, even though the paramedic or EMT knows that that patient does not need to go to the ER, if they want to go to the ER, they have to take them. And typically the hospital is the patient's choice. In the Birmingham area, as you all know, we've lost 3 hospitals through the years. We've lost Lloyd Nolan, we've lost Cooper Green, we've lost Caraway. So once again, the burden's being shared with less hospitals. We lost our trauma center with Caraway. So UAB is the only level 1 trauma center. Children's is the pediatric trauma center. And I was talking to one of the ER doctors the other day, it was last week, that Children's Hospital was on total divert for the first time ever because there was no room to bring in another patient. that the hospital was full and could not adequately take care of a trauma patient. Typically, the trauma centers, they are open all the time for trauma patients. They maintain enough room to be able to handle that level 1 patient. But now, with the number of patients that are being seen, and there's not a room in the hospital for the patient, they're staying in the ER and taking up those trauma beds. But Children's Hospital, for the first time ever, was on total divert last week for several hours. So the system is burdened, and we all have a stake in it. It could be our loved one next. It could be us. It could be our patients that we care for. And there's not a quick solution or quick fix in sight. So with that, I hope I haven't left you with a gloomy attitude and a dark cloud, but I felt like this was a good opportunity to let you know that what's going on in the EMS world, if you didn't already, and that when these guys come in, if they look like they've just been run through the ringer, there's a good chance that they probably have. So I definitely appreciate your time, and be glad to have any discussion or answer any questions right now.
And I'll remind everyone that you have the ability to unmute. If you see at the bottom of your screen, if you move your cursor, there's a little microphone, just click on it. You can unmute and have a discussion. But, I'm full of questions, and everybody on this call is smarter than me. So I've got lots of questions. But my first question to you, Rusty, is as captain, because you talked about funding and lack of resources, et cetera. So as captain, what was your greatest challenge in that role?
Now, once again, I'll tell you, I was very lucky to work where I worked, because we had a lot of resources. But our greatest challenge was when the patients arrived at the ER by ambulance, and they had to wait on the wall, is what we call it, because there were no beds for the patients. So that particular rescue unit or ambulance would be at the hospital sometimes 3, 4, 5, maybe more hours. And that takes them totally out of service until that patient's admitted to the hospital. Now, there's some systems in place now that some days it's better, some days it's not. But I think that was the greatest challenge, being able to adequately care for the patient and get our people back on the road for the next patient.
That's so interesting. I think that most everyone on this call would say that that's their same struggle and challenge is just that. So tell me then your greatest reward or benefit or achievement through that role.
I guess the satisfaction of that role was knowing that we had a great group of professionals on the road that were out there that would do anything they could to save somebody's life when they needed it. And if I and we provided them with the proper equipment and training, that they were going to get out there, and no matter what it took, they were going to take care of our patients.
And so to the funding question, if there's no federal entity through which to funnel and channel funds, how do we raise funds for EMS services other than taxes? Can we reallocate?
It can be reallocated. It can be, special. Some small departments, some rural departments, they have fundraisers. They actually do, fish fries and things like that for the small communities that, have a small department, and that's how they're funded. I think it's just keeping the politicians aware that, EMS needs to be properly funded, and encouraging on the state and the federal level that what money there is that can be given, that it needs to be put into EMS. And a lot of times it kind of slips through the cracks, and other services, other programs get funded. It's definitely holding the politicians' feet to the fire and say, look, you've got to do something, and you got to do something quick. I think Jimmy Stevens is a good example in the Jefferson County Commission. he was presented with a problem in his area of the county, and Jefferson County has spent a lot of money getting a company in that will analyze your community and give recommendations. The county has been given recommendations, and it's up to them now to make it work, to make EMS better in the western part of Jefferson County. But I think Jimmy's done a good job of spearheading that project, and all the other commissioners for that part. But he identified the need, was made aware of the need, and that can happen in cities, that can happen at the state level, and it's just making sure that if your EMS folks in your community or the EMS providers you work with at your facility, if you see a need, it's almost like what they're telling everybody now. If you see something, say something. Same type of deal, just a phone call to a commissioner or to a counselor or something. As far as the private services go, unfortunately, since they're usually private for-profit services, it's up to them to raise their money, although some federal and state funds do go to the private services. But for the most part, if they're a private service in business, it's surely based on their collections of the services, of the cost of the services they provide.
Well, I am just you're like an encyclopedia of EMS. It's just I'd love to have you back sometime just to pick your brain some more. It's nearing the end of the hour, so those of you who aren't able to see a screen, our evaluation link, and again, to receive a certificate as a social worker or nurse, or to have us post your hours to the ABN website if you're a nurse, you must do the evaluation. The evaluation link is https://www.surveymonkey.com/r/all uppercase letters 7YJ9 S as in Sam, W, F as in Frank. This is password protected. Today's password is the name of Rusty's new company, which I'm happy to say is Go Rescue. That's case sensitive. It's no space between go and rescue. GORESCUE, capital G, capital R, no space. Go Rescue is the password for today's evaluation. If anyone has any other questions, you've got many thanks, Rusty, in the chat room. I don't know if you can see it. One of our attendees posted that she was aware of the Tuscaloosa. Some were saying it must be a difficult position that you hold to have so many people that don't do well that you must attend to. Many people are saying it's informative. Ms. Holmes, first set of letters and numbers. Look here in the chat room. And that is the link. And here is password. Ms. Holmes said that was awesome. Ms. Alexander says thanks. Many comments. Thank you so much, Rusty. I appreciate you for doing this for our audience and for me, and for all that you do and have done for many years for others. Thank you so much.
Thank you. Thank you all.
In the presentation for us today, y'all join us on Friday. We'll have Ginger Bentley, a wound nurse, teaching on PICC lines. Vicarious trauma is the 24th, I believe, or 21st. I'll send you all a calendar tonight. The code word and password is the same, Ms. Reddick. I'm sorry, I should correct that language. CEU code word is Go Rescue. CEU password is Go Rescue. If anyone else has issues getting in, please post them now. Otherwise, I'm going to end the meeting for all of us. Thank you so much. Join us Friday and Monday. Thank you, Rusty, and y'all have a great week.